So today's topic is paraplegia, one of common neurological admission and one of common reason of disability. So I have discussed few scenarios with you. Suppose you are in neurology OPD and patient came with sudden onset lower limb weakness. Please keep quiet. Patient came with complaining of sudden onset weakness for last one day when he is awake in the morning, and on examination he is completely oriented, and motor examination of lower limb inspection is normal, tone is increased, power is 0 by 5, reflexes are brisk, and plantar is upward. And along with upper limb examination is completely normal. So where is the issue? Why upper motor neuron here? Okay. Okay, very good. Sir, upper motor neuron. And second scenario, a young female, she is 30-year-old, she is vegetarian and came with complaining of the lower limb weakness for last 2 months along with the numbness of hands.
B12 deficiency.
Okay. Third, a old age male, 60-year-old, and he is hypertensive. He is complaining of the headache and 1 minute. He is complaining of headache and he is confused. On examination, he has difficulty walking. Further examination show there is the power 4 by 5 in lower limb with bilateral plantar upwing. What is diagnosis? Where is the issue?
Upper motor neuron.
Okay. Yes. Yes, he is hypertensive.
It's a bilateral or unilateral?
What bilateral?
It's a bilateral insufficiency or the one?
Bilateral.
Bilateral.
Yes. He is confused. Bilateral weakness. Plantar upwing. Hypertensive. Where is the issue? Yes.
Motor region of cerebellum.
In cerebellum, power is 4 by 5.
What area of the cerebellum is involved?
So means you are saying this is the area of the brain. Okay? Why brain?
She's confused.
Yes, very good. Fourth scenario. A young girl and she is taking high carbohydrate diet. When she is awake in the morning, she has lower limb weakness.
Hypokalemia.
Pain in lower limb, reflexes are absent, plantar is downward. In last night, she is completely alright. When she is awake in the morning, she has pain in the legs along with the lower limb weakness.
Hypokalemia.
Sir, lower motor neuron because tone is completely low.
Okay.
Therapy
Therapeutic neuropathy patient is suddenly lower limb weakness.
Sir, hypokalemia.
Which type of therapy is in which the patient is completely alright in night and she is awake in the morning?
सर हाइपोकेलेमिया होता है
Why hypokalemia?
सर बेसिकली से बैलेंस होता है ना इंसुलिन और पोटेशियम का
Yes, you are right. This is a hypokalemia. So, one hint is hidden in the scenario. High carbohydrate diet. So, everything is discussed in the scenarios. Paraplegia. If any patient with a paraplegia, motor examination is very helpful. Either this paraplegia is due to the upper motor neuron here, either this paraplegia is due to the lower motor neuron here, either this paraplegia which is not fit even the upper motor neuron and not fit into the lower motor. So paraplegia is the word came from the Greek language. Paraplesin means strike at sight. A simple definition is impairment in the motor function of the lower extremities with or without involvement of the sensory system. It is usually caused by the cerebral cortex. In cerebral cortex or in brain cause, only 10% cause paraplegia because mostly brain related is the hemiplegia and monoplegia. So in 10% cases, the brain is involved, responsible for the paraplegia. The second most common cause of the paraplegia is the spinal cord, peripheral nerves, and muscles of lower limb. So paraplegia may be due to the spinal cord, maybe the muscles, maybe the peripheral nerves, and one thing you should add that maybe due to the anterior horn cell disease, and finally brain responsible for the paraplegia. Okay, so we have used two words. One is the paraplegia and second is the paraparesis. What is the difference between the paraplegia and paraparesis?
Paraparesis is partial weakness.
Okay.
Paraplegia is complete weakness.
Very good. So, partial lower limb weakness we are called paraparesis, and complete lower limb weakness, both limb weakness we are called paraplegia. Okay, types of paraplegia. This is very important. That's why I have discussed the scenario. One is the spastic paraplegia. What is the meaning of spastic paraplegia? So, patient is paraplegia, and you are examining the patient. Tone is increased, reflexes are increased with planters or Babinski sign is positive. So, spastic paraplegia is caused by the upper motor neuron glia. Most common reason of the spastic paraplegia is the disease of spinal cord. The spastic paraplegia may be acute, may be chronic. The most common cause of the acute spastic paraplegia is the traumatic spinal cord injury. So history of trauma is present. Infection, and the reason is the transverse myelitis. What is transverse myelitis? There is an infection or inflammation of the spinal cord. Neoplastic is present with a gradual onset paraplegia. Means initially patient is paraparesis, and after few times the paraparesis is converted into the paraplegia. Vascular cause. What is vascular cause of paraplegia? Vascular cause is mostly related to the brain, stroke. So any idea? Sure, but other vascular cause?
Sir, embolism. Sir, thrombosis, embolism.
Yes. Which artery? Very good.
Cerebral.
Two arteries are supplied to the spinal cord. One is the anterior spinal artery and two posterior spinal arteries. So if the arterial of the anterior spinal artery, patient present in the spinal cord infarction. So we are called the vascular paraplegia. Demyelinating disease. What is demyelinating disease? Any idea?
Multiple sclerosis में तो दिया ना demyelinating
What is the meaning of demyelinating?
जिसमें myelin sheath है
Any disease which involves into the myelin sheath. A good example of the demyelinating disease. Very good. Multiple sclerosis.
सही बोला
Degenerative disorders. Old age patient. Back pain. Disc prolapse. Alzheimer's involved into the brain. So we are discussing the spinal cord. So patient is old age. Disc prolapse, disc degeneration can cause spastic paraplegia and nutritional deficiency. Any good example of nutritional deficiency? Vitamin B12 deficiency. So these are the causes of the spastic paraplegia related with the spinal cord. Okay, disease of the brain. Any brain disease which involve both sides of the cerebral hemisphere can cause paraplegia. Both sides of the hemisphere, not on one side of the hemisphere. So paraciliatal tumor, like meningioma, is involved into the both hemisphere. So patient present with the paraplegia or paraparesis. Hydrocephalus, if patient with the meningitis, and he is present with the paraparesis. In hydrocephalus, paraplegia is less likely. Patient present with the difficulty in walking, and when you are checked the power, it is almost 4/5. So hydrocephalus. Other conditions of the paraplegia if the patient is a bilateral stroke. A bilateral stroke of the frontal lobe, because frontal lobe is supplied to the anterior cerebral artery, and anterior cerebral artery is supplied to the contralateral leg. So if the patient is a bilateral anterior cerebral artery stroke, either infarction, either hemorrhage can present with the
Paraplegia.
paraparesis. So it is brain-related causes are account in paraparesis only 5 to 10% cases. It is positive. Third, motor neuron disease. Overall, 2 to 3 types of motor neuron disease. One common type you are seen in the Pakistan, which is still present in the poliomyelitis. So one of the type of the motor neuron disease, primary lateral sclerosis, can present with the paraparesis. And finally, if you are doing any investigation and every investigation is normal and family history is positive, then think of hereditary spastic paraplegia. So spastic paraplegia is diagnosed on the basis of examination. So motor examination is mandatory in every patient with a paraplegia or either quadriplegia. Okay, now came into the flexible paraplegia. What is flexible paraplegia?
Tone decrease होगा lower motor neuron
So
region.
on motor examination, you are seeing the patient. If patient is chronic history, on inspection there is a wasting, fasciculation, decreased tone,
Lower motor neuron
reflexes are absent, and plantar is downward. So these are
lower motor neuron region.
So these all findings are favored to the lower motor neuron region. If patient is lower motor neuron type paraplegia, we are called flexible paraplegia. And what are the causes? Where is spinal cord is aimed? L2 level. So if the patient is lean into the spinal cord, patient is a spastic paraplegia. But if patient is lean below the spinal cord, means below the L2, patient present with the lower motor neuron type paraplegia. Examples are the trauma, infection, Cauda-Equina syndrome, and degenerative disease. Like one of the most common reasons is the disc prolapse. What are the other causes of the flexible paraplegia? Neuropathies. What are the common cause of the acute neuropathy, and what is the common cause of the chronic neuropathy?
Chronic diabetic.
Diabetic
Diabetic
mellitus is
mellitus.
a good cause of the chronic
Acute.
neuropathy, but it is not a common.
Diabetic neuropathy
is the most common cause
Chronic
of the chronic neuropathy.
It will
If
tell
any
you.
patient in your family is the diabetes, he is complaining of the numbness of the hand or numbness of the legs, think of this patient is developed the diabetes neuropathy. Okay, what is the common cause of the acute neuropathy? No. No, hypokalemia is not a neuropathy. Guillain-Barré syndrome,
That's GP.
GPS. Okay?
GPS.
Okay, the other cause is the hypokalemic paralysis we are discussing the scenario. So, history of the high carbohydrate diet, anti-home cell disease, poliomyelitis, national disease of Pakistan. So, these are the common reasons of the flexible paraplegia and the diagnosis on the basis of the history and on the basis of the motor examination. Third, paraplegia with normal motor examination, only power is decreased. So inspection is normal, tone is normal, power is decreased, reflexes are normal, plantars are down. Think of myopathies and think of neuromuscular disorder. Any example of neuromuscular disorder?
Myasthenia gravis.
Myasthenia gravis. Okay, what are other reasons of the neuromuscular disorder?
Autoimmune.
Lambert-Eaton syndrome. Good. Any other? Botulism. Any other? Organophosphate poisoning. So these all include into the neuromuscular disorders. So spastic paraplegia, flexible paraplegia, and paraplegia with no upper motor and lower motor neuron signs. Okay, same we have already discussed the spastic paraplegia, weakness of the muscles along with the increased tone, increased reflexes, and plantar upgoing. It occurs in the upper motor neuron disease due to the loss of the inhibition of the contraction, increased muscle tone, increased feet tendon reflexes, plantar upgoing. Further, it is divided into the extension and flexion paraplegia. So, if we are examine the patient on the motor examination, the paraplegia with there is a marked weakness of the extensor muscle, we are called the extensor spastic paraplegia, or the marked weakness of the flexor muscle, we are called the flexor spastic paraplegia. Flexion paraplegia, decreased tone and contractility of muscle along with weakness. It occurs into the lower motor neuron disease due to loss of the stimulatory innervation to muscle. The findings are decreased muscle tone, wasting of the muscle, absent reflexes, flexion or equivocal plantar with or without fasciculation. The most strongest sign of the lower motor neuron lesion is the fasciculation. Okay, causes of paraplegia, brain-related causes, the cerebrum and brain stem. So we are already discussed the traumatic cause, skull fracture, subdural hematoma on the both sides, not the unilateral side, superior sagittal sinus thrombosis, meningoencephalitis if it is involved into the both cerebral hemisphere, parasagittal meningioma, and very important if you are going into the peds department, there is the child of the cerebral palsy because the cerebral palsy child is the bilateral brain atrophy. Causes in the brain stem, midline tumors. So tumor which is involved into the midline like midbrain pulse or medulla patient present in the paraparesis. So bilateral lesion or midline lesion in the brain is responsible for the paraplegia. Spinal cord, we are classified intramedullary. What is the meaning of intramedullary? Means inside the spinal cord. Extramedullary means outside the spinal cord but inside the dura. And extradural means outside the dura. So these are the causes of the lesions of the intramedullary. This is pharyngomyelia, hematomyelia, and tumors. Extramedullary like tumors, and extradural vertebral fracture, tuberculosis, infection, Port's disease. What is Port's disease? It is also called the TB spine. Congenital causes, neoplastic, and finally paravertebral abscess. Infective causes of the spinal cord disorder, bacterial, viral most common is the polio and herpes simplex. Inflammatory causes are the transverse myelitis, immune system, autoimmune disorders, post-vaccination, and demyelinating. Most common is the multiple sclerosis. So these are causes we are already discussed previously. Hereditary causes, toxic myelopathies. What is the definition of myelopathy? What is myelopathy? If patient is a muscle disease, we are called myopathy. If patient is a spinal cord disease, we are called myelopathy. So toxic causes of spinal cord disease are the arsenic, spinal anesthesias, and vascular causes there is the occlusion of the anterior spinal artery due to the thrombosis. Metabolic causes, vitamin B12 deficiency is very common in our country. Tropical, neoplastic, and physical agents like radiation and electrical shock to the spinal cord. So all these are causes of the myelopathies or the spinal cord disease. Okay. Clinical features. In addition to weakness of the lower limb, other clinical features depend on the cause of the paraplegia. If the patient is a paraplegia, what other associated symptoms are important? And cerebral paraplegia means patient is paraplegia related with the brain, weakness of upper limb sometimes present, mental retardation means patient is drowsy, unconscious, or patient is an abnormal behavior, sometimes delayed milestone, fits, and altered sensorium. So any patient present with the paraplegia and his consciousness is not impaired and there is a history of the seizures, think of this paraplegia as under the brain pathology. And second is the spinal paraplegia. There is the spasticity, brisk reflexes, and there is the sensations lost at the level of the spinal cord. Distal weakness, sensory loss, muscle atrophy if the patient is a paraplegia, along with the muscles atrophy and absent reflexes, think of the neuropathies. Okay, history. History is very important. History like sudden onset and gradual onset. What are the causes of sudden onset paraplegia? History of trauma is very important. Fracture, dislocation of vertebrae, infections like epidural abscess, and epidural abscess there is history of fever is present. Vascular causes like patient is a history of the abdominal surgery and abdominal trauma, and other is the transverse myelitis. What is transverse myelitis? So, transverse myelitis is the infection of the spinal cord. These are the common causes of the acute onset of the paraplegia. The second is the gradual onset. So, history is prolonged. Patient is the paraplegia and history is more than 1 month. In acute onset, we are called if the history is less than 1 month, and gradual onset, the history is more than 1 month. So, what are the gradual causes of the paraplegia? Neoplastic, like tumors, which tumors? Meningioma, ependyma, and astrocytoma. Duration of symptoms short in the traumatic cause, infective cause, along with the duration of symptoms are long if the patient is a hereditary problem, congenital problem, neoplastic problem, and demyelinating problem. What about the sensory? What is the sensory level? If patient is the paraplegia and you are examine the sensory system, decrease pain and temperature sensations up to level of the lesion. So we are called the sensory level or sensory symptoms. Common sensory symptoms of paraplegia are the numbness, pain, and paresthesias and burning pain. Okay? Associated symptoms. If the patient is a fever, along with the paraplegia, think of the infection. Any history of the seizures. If the patient is a paraplegia, along with the patient is a fits, think of the reason of paraplegia is related with the brain. Other causes, delayed milestone, which is associated with the cerebral palsy. Other causes like vitamin deficiency. So in any patient, birth history is very important for the patient. If the delayed milestone, think of the cerebral palsy. Every patient, the history of fever is very important. If patient is a paraplegia related with the fever, think of the infection cause. If patient is a strict vegetarian diet, think of the patient is a vitamin B12 level deficiency. Okay, other question which is associated with the paraplegia is very important. Sphincter problem. So sphincter problem like urinary retention, urinary incontinence, or constipation or fecal incontinence, these are associated mostly with the spinal cord. If patient is a paraplegia and then it is a children, birth history is very important. Okay, examination is very important. Of neurological examination, the most important is the start from the higher mental function. If patient is oriented, conscious, calculation, memory is normal, then think of the reason of the paraplegia related to the brain is excluded. If patient is confused, patient is drowsy, then think of the paraplegia is related with the brain related. Second step of the neurological examination is the cranial nerves. If the patient is a paraplegia and there is the involvement of the cranial nerves, think of the patient is region of the brain or brain stem. If there is no cranial nerve involvement, brain is excluded. Third is the motor examination, which is already we are discussed. In motor examination, if the tone is normal, reflexes are normal, and plantar is upwind, think of the spastic paraplegia. If reflexes are absent and plantar is downwind, think of the flaccid paraplegia. Sensory examination is very important to assess the sensory level. Sensations related with the pain, temperature, if these are present, think of the spinal cord disease or peripheral neuropathies. proper examination of skull and spine to look for any localized tenderness, depressed structure and deformities. So neurological examination is very helpful to identify the paraplegia related with the upper motor neuron, lower motor neuron or related with the no upper motor or lower motor neuron cause.
सेम है बस पूरी थी हुई तो कला
Okay, now came into the investigations. If patient is paraplegia, first investigations are the routine investigation. We have discussed the routine investigation. Blood CP is helpful or not? Why? So, one thing is the infection. And which component is helpful for the infection? Very good. So, WBC count is associated with the infection. Okay, other parts of the blood CP? Anemia. Which type of anemia?
Megaloblastic.
So, which component is helpful for the megaloblastic anemia?
B12.
MCV level. So, MCV level is helpful for the macrocytic anemia, not for the megaloblastic anemia. So, second is the MCV level. Okay, which other component of the blood CP is related with the paraplegia? So, one is the WBC, second is MCV, third is why hemoglobin level? Yes. Hemoglobin decrease maybe due to the other causes of the anemia. Platelets count is very helpful. If patient is the platelet is less than 1 lakh, there is the chances of the spinal cord hemorrhage. So hemorrhage may be occur due to the spinal cord or due to occur to the brain is due to the thrombocytopenia. Okay, after blood CP, which investigation is very helpful for the paraplegia? Why electrolytes? Very good. Serum potassium level. If serum potassium level is high, we are called hyperkalemic periodic paralysis. If potassium level is very low, we are called the hypokalemic periodic paralysis. So these are the routine investigation. Which other blood test is helpful for the diagnosis of the paraplegia? So vitamin B12 level is very helpful. If the patient is a paraplegia and the upper motor neuron sign or mixed sign, vitamin B12 level is very important. The other investigation is the X-ray. X-ray spine. If the patient is a paraplegia due to the thoracic spinal cord or lumbosacral spine, which findings are you are seen into the X-ray?
सर हेमाटोमा वगैरह
Yes. This location mostly we are seeing into the MR. MR is more special. Particular fractures, bony deformities, these are more important we are seeing into the X-ray. So bony fracture, bony abnormality, these are very important. Osteophyte formation. If the patient is of old age and patient is the paraplegia, one of the common reason of the paraplegia is the osteoarthritis. Osteoarthritis may be involved into the vertebral body. So osteophyte formation and college vertebra. CSF examination. Why CSF examination is helpful for the paraplegia?
meningitis
So meningitis involves the spinal cord. So complete CSF examination includes CSF VR, CSF culture, CSF PCR, CSF cytology, and CSF for oligoclonal band. What is oligoclonal band? Okay. CSF DR is helpful for the infection like transverse myelitis. CSF cytology is helpful for the neoplastic cause. CSF PCR is helpful if the patient is a viral transverse myelitis, and CSF oligoclonal band. These are the types of the proteins, and these are positive if patient is a multiple sclerosis. So if you are seeing the word oligoclonal band, you must be think this patient is the issue into the demyelinating or multiple sclerosis. So second investigation is the CSF examination. CT scan spinal cord is helpful if the patient is bony abnormalities. So if the patient is a paraplegia and you are think this patient is a paraplegia due to the trauma, CT scan is helpful. Spinal cord is not identified into the CT scan. So CT scan is only helpful if patient is an issue in the vertebrae or bony pathologies. More specific and sensitive case if the patient is a spastic paraplegia is the MRI spinal cord. If the patient is a quadriplegia, then MRI cervical spinal cord. If the patient is a spastic paraplegia, then MRI dorsal spinal cord. If patient is a flexed paraplegia, then MRI lumbosacral spinal cord. So MRI spinal cord or MRI lumbosacral area is helpful if the patient is a spastic or patient is a flexed paraplegia. If patient is a paraplegia along with the consciousness is impaired or the cranial nerves are involvement, then MRI brain is very helpful. So more specific case for the spastic paraplegia is the MRI is compared to the CT scan or lumbar puncture or plain X-ray. Okay, what is the meaning of compressive myelopathy? Yes. If any pathology which is came from the outside and compress the spinal cord, we are called the compressive myelopathy, and it is identified on the basis of investigation. Clinical basis, we are not differentiate this patient is a non-compressive myelopathy or this patient is a compressive myelopathy. So compressive myelopathy is the reason of the spinal cord disorder due to the compression from the outside. Okay. We have discussed some disease related with the paraplegia. The first disease is the syringomyelia. Any idea of the syringomyelia? Yes, good. So, cystic dilatation of the spinal cord caused by the obliteration, the flow of the sessile from the spinal canal, so it is absorption. Syringomyelia mostly occurs if the patient is a cervical spinal cord. It is less likely into the dorsal spinal cord. And what is the specific point related with the syringomyelia? Any specific point which is related with the syringomyelia?
C3, is that right?
Pain and temperature sensations are lost and preserve the vibration sensation. So, syringomyelia initially pain and temperature sensations are lost and there is the preservation of the dorsal column. That's why word used for the syringomyelia is the central cord syndrome. Why central cord syndrome? Because it is destroyed from the central, then it is spread to the periphery. Okay. These are vertebrae. And a blade space between the vertebrae is the disc. And the blade snake-like structure is the spinal cord. And this white structure is the subarachnoid space. And these are the muscles and ligaments. So, muscles and ligament, subarachnoid space, spinal cord, vertebrae and disc. Where is issue in this MRI? There is issue in the white layer. So, if the issue within the spinal cord, we are called intramedullary. If the issue outside the spinal cord, we are called extramedullary. If the issue within the subarachnoid space, we are called extramedullary, intradural. But if the pathology is came from the outside, we are called extradural. So this is a classification of layer on the basis of anatomical location. आवाज आ रही है सबको? इसमें ज़्यादा comfort. ठीक है, so this is a MRI और ये एक lesion नजर आ रहा है. So where is the location of this lesion? So it starts from the intradural. So outside of the brain, spinal cord, and it is involved into the spinal cord. So this is a lesion of the pharyngeomyelium.
Extramedullary or subdural?
The second condition is the hematomyelia. What is the hematomyelia? We have discussed the blood CP, thrombocytopenia, hemorrhage in the spinal cord. So hemorrhage into the substance into the spinal cord due to the trauma, vascular malformation, bleeding disorder or spinal cord neoplasms. Present acute transverse myelopathy and diagnosed on the basis of the MRI. Very important epidural abscess. Which point is more familiar to the epidural abscess on the basis of history? Fever. Very good. So patient is history of the fever. If the fever is high grade, think of the acute bacterial or acute viral. If the fever is low grade and gradual onset, think of the tuberculosis or fungal. So high grade fever and low grade fever which is associated with the epidural abscess. It is occur anywhere into the spinal cord. Risk factors are the patient is the immunocompromised or infection of the soft tissue. The presentation is a high grade or low grade fever, low level weakness along with the pain. Okay, very important. Port disease. Favorite questions of your medicine related examiners. What is port disease? Which organism is helpful? Which organism is responsible? So port disease we are called the TB, spine or tuberculosis spondylitis infection which is by the blood spread and mostly it is involved into the paravertebral lymph nodes and finally involved into the vertebrae. So TB spine is mostly involved to the vertebrae, then these are involved into the spinal cord. So most common site of the TB spine is the upper thoracic. Most common site of the pharyngomyelia is the cervical. Most common site of the disc prolapse is the lumbosacral. Most common site of the TB spine is the thoracic. So these diseases are divided their areas. Okay. From the one vertebral body, and slowly reach the adjacent vertebral bodies and affect the intervertebral disc. So tuberculosis spine is involved in the dorsal spinal cord. Patient mostly present with the spastic paraplegia. And what is the duration of the anti-tuberculosis therapy for the patient in the post disease?
6 months.
9 months.
1 year to 9 months.
9 months.
Latest guidelines show there is a 1 year to 9 months. Okay, a very important slide. These are vertebrae. 1, 2, 3, 4, and a disc, spinal cord,
Yes.
subarachnoid space, and muscle.
Muscle.
Where is the issue? Prolapse of vertebrae. These vertebrae in life, and there is a prolapse of one vertebra, and this vertebra is compressed the spinal cord. So a word used for this image is the compressive myelopathy. Okay, 3 histories are very important. History of trauma with no fever. Think of traumatic compressive myelopathy. History of low-grade fever, weight loss, and paraplegia. Think of tuberculosis. History of smoking, weight loss, no fever, paraplegia. Think of malignancy, metastasis. So history is very, very, very important. Trauma, fever, smoking. So smoking most favored to the malignancy with no fever, fever most favored to the tuberculosis, and trauma most favored to the traumatic spinal cord injury. Anterior spinal artery infarction, and we are called stroke of the spinal cord. Anterior spinal artery is supplied to the two-thirds of the spinal cord, and infarction causes anterior cord syndrome. What is the cause of the central cord syndrome? Pharyngiomyelitis, which is already discussed. The reason of the anterior cord syndrome is the anterior spinal artery occlusion. Okay, what is the unique point of the anterior spinal cord artery infarction as compared to the transverse myelitis? In transverse myelitis of the spinal cord, patient is a spastic paraplegia, and patient due to the anterior spinal artery infarction can cause spastic paraplegia. So what is the differentiate between these two causes? Very good. In transverse myelitis, all sensations are impaired. In anterior spinal cord artery syndrome, the dorsal column is normal. So if patient is a spastic paraplegia and the sense of position and sense of vibration are normal, then think of the anterior spinal cord infarction as compared to the transverse myelitis. So what are the causes and what is the treatment? There is a treatment. Sometimes we are given the anticoagulant therapy. AV malformation of the spinal cord. Okay? So, patient is a spastic paraplegia and you are doing the MRI dorsal spine. There is the AV malformation normal and the treatment is the surgery. So, I think this topic is more important to discuss the neurosurgeon as compared to the neurophysician. So, we are refer this patient to the neurosurgeon. Hereditary spastic paraplegia. If the patient is a spastic paraplegia, all causes are excluded and family history is positive. Patient brother, patient sister has same problem and all investigations are you are ruled out any structural or vascular causes, then think of the hereditary spastic paraplegia. Very important for vegetarian students. Subacute combined degeneration of spinal cord. Okay, one question. Which trait are involved if patient is a subacute combined degeneration of the spinal cord? Yes. Which dorsal? Dorsal column. So one trait is involved in the dorsal column. So loss of sense of position and sense of vibration. So this is one trait. Other? Yes? Corticospinal trait. So bilateral plantar upward. And peripheral nerves. That's why reflexes are absent. And spinal cord. Okay, so the patient of subacute combined degeneration of spinal cord present with decreased power, plantars are upgoing and absent reflexes. So mixed paraplegia, mixed signs paraplegia. What are additional signs, neurological signs of subacute combined degeneration of spinal cord? Dementia, good, and last one. Neurological. We have already discussed peripheral neuropathy, optic atrophy. So, neurological complications of vitamin B12 deficiency, dementia, optic atrophy, paraplegia, plantar upgoing, absent reflexes, impaired dorsal column. Okay, what is the treatment option? Vitamin B12. What is the dosage? Paraplegia. Hydrocephalus. Patient is high grade fever. Patient is confused. Patient has fits. And patient is difficult in walking. On examination, patient is confused. High grade fever, and further examination show there is the increased reflexes with plantar abdomen. And you are advised the CT scan brain. And CT scan show there is the dilatation of the ventricles. So, hydrocephalus. Okay, a question. What are the types of hydrocephalus? So, there are two types of hydrocephalus. Very good. Which types? And how would you differentiate on the basis of the CT scan? Either this is a communicating or non-communicating hydrocephalus. So dilation of ventricles is both communicating and non-communicating. Yes, very important. If ventricles, you are focused on the ventricles and fourth ventricle is dilated along with the other ventricle, this is a non-obstructive. If other ventricles are dilated but fourth ventricle is not dilated, then this is an obstructive hydrocephalus. So obstructive and non-obstructive hydrocephalus are diagnosed on the basis of the fourth ventricle. Okay. What is the treatment of hydrocephalus? VP shunt, ventriculoperitoneal shunt. Very good. Most important reason of the acute flaccid paralysis. The one is the poliomyelitis and second is the Guillain-Barré syndrome. These topics we are discussed if we are going into the final year. So which point are favorite to the Guillain-Barré syndrome? Any? Very good. Ascending paralysis. And what is the meaning of ascending paralysis? So patient is complaining of the weakness of the foot, and these are spread involved into the legs, and these are involved into the upper limb. So ascending paralysis, areflexia, these are the common features, and acute onset, AAA. Acute, history less than 1 month, ascending, and areflexia. These all points are favorite to the Guillain-Barré syndrome. And what is the management of Guillain-Barré syndrome? A procedure is performed like dialysis, we are called the plasmapheresis. So plasmapheresis is the treatment of choice of the Guillain-Barré syndrome. So if you are seeing the word Guillain-Barré syndrome, think of the A3, acute, areflexia, and finally ascending paralysis. Very important. Transverse myelitis. What is definition of transverse myelitis? Inflammation or infection of spinal cord. A good scenario. Patient is sleep normal. When he is awake in the morning, he feels back pain and lower limb weakness and urinary retention. On examination, power is 0/5, reflexes are brisk, plantar is outgoing, and sensations are decreased up to the umbilicus. So acute onset, upper motor neuron with decreased sensation up to the umbilicus between T10. So this is a good scenario of the transverse myelitis. Okay. Management. Few slides. Overall, the management of the paraplegia, general management, frequent change the patient posture, care of the skin and care of the bladder. Physiotherapy is very important in every type of the paraplegia like flexible paraplegia, spastic paraplegia or mixed paraplegia. Symptomatic treatment, if the patient is a pain, you should give the painkillers. Special treatment, if the patient is a DB spine, you should give the antituberculosis drug. If the patient is an abscess, there is a need of the surgery. If patient is a transverse myelitis, you should give the IV antibiotics. If patient is a Guillain-Barré syndrome, there is the plasmapheresis. Last, complications of paraplegia, if you are not treated properly, bed sores, contractures, urinary tract infections, pneumonia, and finally deep venous thrombosis. Thank you so much. Any question? Thank you.